Okay, so, well, but it's in the program, and I was asked to do this, promise. Why does the future of endoscopic surgery look bright and better? So, microsurgery, when it was introduced in the 80s, huge advantages, huge advancement in comparison to open surgeries, because that was a big step in reducing the invasiveness of these surgeries. For a number of reasons, I don't want to outline this here. Now we are we're at a point where we have something, the microscope, which is very, very good. The question is, why should I take that step and go through another learning curve? And the ultimate question is it worth it to go through this learning curve? So I'll tell you my perception on this. My personal background, just so that everybody here knows, this is my background. I've grown up with a microscope, and over time and over the years, I have made more and more of the transition to going to the endoscope. So this here is my experiences. What is the advantage? It's a very much developed technique. We have all kinds of approaches. We have all kinds of instruments. We have burrs, we have scissors, we have Kerenson rongeurs, we have good visualization. So at the end of the day, we have everything from the tools, from the technology. The technology nowadays is developed enough that we can actually address all of pathologies. And now this is a literature overview, which my mentor, Michael Meyer, published a while ago. Indications for endoscopic surgery. You can do discectomies, decompressions, recess decompressions, synovial cyst, cervical, thoracic, lumbar spine. You can do revision cases. So technically speaking, you can do all of that with an endoscope. And why is the future of the endoscope bright? Is because I think we will see more and more developments in other areas. For example, interbody fusion. So look at that. We're going into the desk space. We are nicely cleaning the disc and the cartilage from the adjacent vertebral bodies. Okay, you can use shavers, you can use dissectors, you can use Kerensons. You can even go to the contralateral side, so you get good implant placement. And then you can put in implants. And then you can even, full endoscopically, we will also be able to do interbody fusion techniques. And then this is how an implant placement, what it looks like at the end of the surgery. So there are more and more developments coming over time. So you saw from the indications, technically speaking, there is no limit. We can do anything that we need to do. The question is much more, do you think that you, at your stage of your learning curve, do you feel comfortable already to do a decompression, to do a cervical spine, or you say, maybe not so comfortable yet, maybe I'll keep this for in whatever, 4 or 5 years' time. Okay, so the technique is not the limit, it's much more the surgeon, the handling, the learning curve. And I think that we will see more and more endoscopic because there are real advances in surgeon education. Nowadays, everybody can go online and you can watch the YouTube videos and you can come and visit us, and and also we heard about it yesterday. I think navigation will play a role, because you always have control where you are. For example, when you're working transraminally, you know where you are. You know that maybe you're going a little bit too far cranially in the foramen, which is a risk of injuring the cranially exiting nerve root. So I think for the learning curve, the navigation will play a role. And I think overall, just the endoscopic techniques will become more and more accessible all around the world. So where are particular advantages? Why is it worth it to use the endoscope? First of all, the invasiveness is really, really minimal. You have these small incisions, patients have minimal wound pain, they can immediately mobilize, and a lot of these procedures you can do on an outpatient basis. Yeah? In Germany, we cannot, but the problem is not a medical problem. So if you compare publications coming from the US and from Germany, for example, You know, the US surgeons always think, why are we, the Germans, doing the surgery so badly because the patient stays so long? No, this is only because of our reimbursement system. If I do the surgery and the patient goes home same day, they will deduct 40% of our reimbursement. So we have to tell the patient that we still need to check them, and they can only go home 48 hours after the surgery. So that's something, a lot of these decisions are not medical decisions, they're simply reimbursement driven, okay? But otherwise, if the situation is different here, then you can do a lot of the surgeries on an outpatient basis. The visualization of the microscope is good. That of the endoscope is absolutely flawless, if you see it. That is because you're right next to the neural structures, you have the 25-degree angled optics, you have 4K systems, so I think the visualization is even better working with an endoscope. Everybody is always asking, you know, we need evidence, the gold standard. You know, gold standard, that's the one thing. Gold standard is always a technique that's 30, 40 years old, and that's why it's now the gold standard, but that also means that it's the old standard. That's why it's the gold standard. Okay? So everybody's always asking for more and more data, and look at that study. That was one of the biggest meta-analysis that was done, comparing discectomy, endo versus micro, and they are the same for a number of outcome parameters. The endoscope is better, and that's why those authors concluded that there is a potential for the endoscope in the future to maybe take over as a gold standard. We have a significantly increasing number of obese patients in Germany, in the US, and all around the world. And I can tell you that I am so happy to have the endoscope for this patient cohort. Because if you do a surgery, like a decompression, like a discectomy, in a patient 140 kilos, with only a 6, 7, 8 millimeter incision, that really changes everything. Yeah? And technically speaking, you're doing the same surgery. So it's much easier to operate an obese patient endoscopically than microscopically or open. So huge advantage here in this. And I showed you this already. Then you can do these nice and elegantly. And another huge advantage, we talked about complications. You can have recurrent disc herniations, you can have hematoma, you can have dural lesions. The one complication that is virtually, that you can eliminate, that is virtually almost zero, so there's never 0% in medicine, but you get as close to 0% as that of infection or wound healing problems. It's virtually almost zero. So let's say you do a discectomy, patient could still have a bad tooth and you can get a discectomy. So that's why I'm saying there's no 0%, but it's almost 0%. And just imagine how many congresses have we gone to, and we have talked about increasing resistance against antibiotics and the rise of superbugs and infections and wound healings. If we change all of our procedures to endoscopic, that would have a huge impact on infection and bugs and resistances all over the world. So, like I said, we can almost eliminate the risk of this by going endoscopic. There's a learning curve. We always talk about that. The one aspect when we talk about the learning curve is what is the easiest technique, but also what is the best technique. And me personally, I think if we look at it over the time, and if you look at the last 50 years, we have seen huge advantages from doing laminectomies to doing this, to going from open to micro. And I think for the same advantages, and we know, you know, it's less mobility, patients are active, faster. That's why I think that we will see more and more endoscopic cases also coming in the future on a global scale. So now I promise I'm finished. Thank you very much for your invitation.